Last year we began the Nonie Lowry Oration in memory of Nonie, who was the founder of LP and the company that has provided management for the Western Surgical Association and many other surgical associations to which you may be a member for many, many years. Nonie was simply the nicest, sweetest, most welcoming person that I've ever known. I would see her at many different meetings, and she was always someone who brought a smile to your face and was just a joy to be around. I'm sure everyone felt the same way. It was always wonderful to go to this meeting and know that Nonie was going to be there, and you'd always have a friendly face and someone who made you feel at home. Nonie was taken from us way too early, but her memory and her spirit live on here at the Western Surgical. Her mother, Nora, and sister, Margie, are here, and I know that Nonie's with us, so in her honor, we have this address each year. This year's Nonie Lowry Orator is one of the giants in the world of surgery, Dr. David Nagorney. He went to medical school and went to the University of Kansas and went to Mayo University School of Medicine. He did some hepatobiliary training after his residency at Mayo at the Hammersmith Hospital in London, and then has had his entire career at the Mayo Clinic as chief of their hepatopancreaticobiliary service and director of their fellowship in HPB surgery. Dr. Nagorney is widely recognized, is world-renowned as one of the finest hepatobiliary surgeons in the world. He's published over 400 papers. He is truly one of the giants in the world of surgery. And there are a lot of people who do liver surgery. There are a lot of painters out there. There are a lot of house painters, and there are only a few Picassos. And I can tell you Dr. Nagorney is one of the Picassos of liver surgery. He's going to talk to us this morning about treatment of hepatic metastases. Dr. Nagorney, thank you so much for your kind introduction of me, and thank you for giving the Nonie Lowry Oration.
Thank you very much, Kelly, for your kind introduction. I also thank you for not spilling water on my talk like I didn't spill water on yours when you gave your talk. I'm also very pleased for the Society's invitation to present the Nonie Lowry Oration. I have nothing to disclose, although I do have a little bit of angst and trepidation about giving this talk. Like many of you, I too knew Nonie as a very special lady. She was a talented, engaging woman with a warm smile and confident demeanor who worked very hard and tirelessly for the Western Surgical. I hope my comments will merit the honor of the oration in her name. Admittedly, I was pretty surprised about this invitation. I'm a fairly reticent guy, and so getting up and talking a lot is not my usual cup of tea. I'm not sure what criteria I met, but nonetheless, here I am, and I am honored. The choice of topics for me was difficult because the topic was open-ended. I finally chose to talk about metastasis because the Mayo Clinic and my mentor, Marty Adson, a past Western Surgical president, has played a seminal role in addressing hepatic resection for metastatic colon cancer. And it's an area where I've had a little bit of experience. John Waugh from the Mayo Clinic first wrote about Mayo's experience of resecting hepatic metastasis in 1963. The time was not right for pursuing hepatic metastasis at that time. Marty Adson presenting a paper here at the Western Surgical in 1975, revisited that issue and essentially presented a matched group analysis of 60 patients who were resected against 60 patients who were not, showing the potential advantage of resecting metastases. And the timing was then right, and the chase began. Many of you in this audience have made major contributions in this area. Much has evolved over the 50 years. In fact, the chase is a great example of surgical persistence, which led to a widespread multidisciplinary approach for patients with a very common clinical cancer. It's a symbiotic success for medical and surgical oncologists. The pursuit of colorectal cancer has supported a basic hypothesis of cancer theory, that is oligometastasis, and the management has demonstrated how practice evolves from clinical ingenuity. Mind you, this oration won't be, I was going to say TED Talk, but instead I'm going to say a Kelly Talk. But I'll do my best to engage you and bring perspective to the surgical trek that the surgical community has undertaken over the last 25 years. I intend to highlight milestones or key turning points in the management of metastatic colon cancer to show how far we've come. Each area is a talk in itself. However, all physicians agree, or at least those who manage these patients, that hepatic resection plays a key role in the multidisciplinary management of hepatic metastasis, curative in some, progression delaying in most, and disappointingly ineffective in many. I'll focus on three areas: accomplishments, current challenges, and future opportunities. Although these areas may be applicable to other metastatic disease process to the liver, I'll focus only on colorectal cancer. In the 1970s, radiation and medical oncology had little to offer patients with metastatic colon cancer. Resection was justified as the benefit of the doubt. That is, it's the only chance for cure, so let's do it. Unknowingly, surgeons who pursued resection of liver metastasis were providing clinical data and observations that led to the subsequent oligometastatic theory of cancer progression by Hellman and Wishelbaum. That is, a distinct biologic state of limited metastatic disease as an intermediate step of tumor progression. The clinical implication was that if you take out this disease, you can provide long-term survival for some patients. And I think our work in hepatic metastasis has proven that concept. We continue to struggle with selection, which my mentor philosophically described as the capriciousness of the metastatic process. The clinical conundrum remains of identifying the true oligometastatic disease so that we can cure these patients. The chase for metastasis actually began in earnest in the mid-1970s when Foster and Bierman published their classic treatise on solid liver tumors. Only 109 resections for colorectal cancer were performed at that time, and only 126 additional cases were obtained in a registry reported in 1974. Resections were typically minor, metastasis few, and adjuvant therapy nil. 5-year survival averaged 24%, with a natural history of 1% survival, with a median survival of 2 years. However, this 24% operative mortality was at expense of an operative mortality rate of 17%, which is truly high. We recognized heterogeneity of patients back then, but selection still remained imperfect. Resection efforts were indeed bold. We've come a long way. Today, the expected overall 5-year survival is 60% for all major cancer centers and even 70% for solitary metastasis. Operative mortality is now just about 1% or less. Outcomes have truly dramatically changed. These results are not only limited to specialty centers, but these registry data confirm broad reproducibility of chasing colorectal metastasis. This report of the International Registry of over 13,000 patients had only a 2% operative mortality with a 15% hepatic-specific morbidity rate. So this is widely applicable to all people. How is this accomplished? Well, improved techniques have led to resection becoming very safe. Selection of patients is now not based only on phenotype, but also becoming oncologic based on tumor biology. And finally, surgeons and medical oncologists realized that multidisciplinary management was a key to success, which didn't occur at the time of Dr. Adson's start. Multidisciplinary management works, cooperation, not confrontation. If only our Congress would follow our lead. I'm a big fan of tactics over strategics, so I have to comment on technique. Point one, hepatic resection has become safe over the years. Significant advances occurred in the 80s and 90s, though selection remained relatively conservative during that time frame. Many of you here contributed to the change. Key factors of improved safety of hepatic resection include applied anatomy and the recognition of resilience of the liver to ischemia and its regenerative capacity. Vasculature was controlled with reduced operative blood loss and hemodynamic consequence by pleural triad clamping and total vascular isolation. Liver transection vessels, ducts, and parenchyma became standard, either by stapling devices or parenchymal transection devices. Anesthesia with low CVP anesthesia has made operations safer to reduce blood loss. And most importantly, volume, function, and regenerative relationships of the liver have been now fully understood, or at least more fully understood, and applied in our operations. These advances have led to a reduction in operative mortality now to less than 1% for even major resections at major cancer centers. Importantly, the driving force for these changes were primarily related to operations related to colorectal metastasis as opposed to primary hepatic malignancies. As a consequence of the safety afforded by surgeons by these early technical advances, the technical limits were pressed, yet the mortality and morbidity stayed the same. Advanced techniques are all predicated on fully grasping the importance of the functional liver remnant, with Nick Vothe and Eddie Abdallah and others in this room have promulgated. Parenchymal sparing resections, though sounding simple, can be quite complex and are done well. Portal vein embolization to prepare the functional liver remnant is widely used. Staged hepatic resections, which I'll briefly touch on, have now become standard for very advanced bilobar metastatic disease, whether by PVE preceding things or by the ALPS procedure. And resection alone is not enough. We combine resection with ablation and hepatic artery infusion chemotherapy, or all the above. Once standard hepatic resection became safe, staged resections were developed to address extensive bilobar metastases. Initially, as perhaps Dr. McMasters would say, we went all in. We played all your cards, no second stage. You'd do a major resection, minor resection, and hope that the liver remnant would be good enough to get patients through. That was not the wisest way to go. Subsequently, major resection was followed by in situ liver growth, and then minor resection of the residual metastasis, and the remnant was pursued. That was a better idea. However, the focus was on tumor bulk and not the functioning liver remnant. The best idea was promulgated by Renee Adam and Nick Vothe, as well as Eddie Abdallah, who have emphasized the priority of the functional liver remnant for patient safety and overall outcomes. ALPS, although conceptually similar to the postoperative PVE approach, shortens the interval between staged resections. However, the role of ALPS is still evolving and remains unclear. These technical advances summarized here would not have had the impact without current advances in chemotherapy, which I'll touch on briefly. The second important thing that has evolved with resection of liver metastasis has been selection of patients. Selection of patients is critical. Initial selection of patients for resection was really based on very defined criteria: control of the primary tumor by having it resected first, and limited liver disease. Phenotypic or clinical pathologic factors were correlated with outcome and became gross surrogates of tumor biology for selection. Thus, prognostic scoring systems and clinical nomograms evolved. Some have been validated, but its use is variable and not widespread. Every institutional series has examined clinical pathologic correlates of survival. All have attempted to define criteria for patient selection for therapy. These representative studies show overlap but inconsistent correlation with survival after resection alone. No doubt there's great clinical pathologic heterogeneity, which most certainly implies oncologic heterogeneity. Yuman Fong was the first to propose a prognostic risk scoring system for metastatic colorectal carcinoma based on 5 clinical pathologic factors to stratify patients for adjuvant chemotherapy to improve outcome, but really not for selection of patients for operation. Unfortunately, overall survival for any group was not good enough to predict the use of effective adjuvant chemotherapy, which unfortunately didn't exist at the time, and even some of the patients with all adverse factors still survived 5 years. This limited the utility of this scoring system for selection of operation. Other prognostic scoring systems and nomograms were developed, some complex, some simple. All stratify outcomes and identify candidates who benefit the most and the least from resection alone. However, to date, none of these scoring systems clearly defines the patient who will not benefit from operation. And conversely, no system defines which patients have a good enough survival to preclude consideration for effective modern adjuvant chemotherapy. Although clinical pathologic selection criteria for resection have been refined and prognostic factors still remain relevant, surgeons recognized that these factors had limited value for prognosis and patient selection and began to look for better surrogates of tumor biology. The next major point is clearly that concurrent advances in systemic chemotherapy for colorectal carcinoma have made a major impact on the management of this disease process. Metastatic response to systemic chemotherapy is the major defining factor defining oncologic resectability, and that requires multidisciplinary management. Outcomes for resection of liver metastasis from colorectal cancer were stagnant until effective chemotherapy arose. The efficacy of chemotherapy ushered in the oncologic operation. Independent serial management of metastatic colorectal cancer to the liver by surgeon and then oncologist became interdependent and concurrent. Nonetheless, routine addition of chemotherapy is not a perfect world. Lessons in type, timing, and duration of chemotherapy and hepatotoxicity had to be learned over the years. Let's highlight some of the chemotherapy, how chemotherapy has affected the surgical management of colorectal cancer. First, adjuvant therapy was undertaken to improve outcomes. To date, no randomized controlled data of adjuvant chemotherapy after potentially curative hepatic resection has proven survival benefit. These pooled data from 2 randomized controlled studies showed a trend toward improved survival, but if you're a purist statistically, it didn't reach statistical significance. Pooled analysis did support independent association with improved progression-free and overall survival, but that chemotherapy was not as modern as we have to date. Subsequent studies analyzing all studies of adjuvant chemotherapy, whether very good controlled or consecutive series or controlled studies, have supported an improved overall survival and recurrence-free survival for adjuvant chemotherapy. Adjuvant chemotherapy has improved overall survival in approximately 23% of the patients and recurrence-free survival in 29% of the patients. Although this is not level 1 data, this a priori evidence of efficacy supports adjuvant chemotherapy as our current standard. With cumulative evidence supporting increasing cure for some patients by adjuvant chemotherapy, others thought to increase candidacy for resection as the next milestone. More patients have unresectable than resectable hepatic metastasis. Could that be changed? Bismuth and Adam first intensively evaluated conversion chemotherapy, that is, downsizing unresectable to resectable metastasis. This initial study was landmark and showed that modern chemotherapy could alter technical resectability, with survival benefit further expanding the role of hepatic resection for these patients. How often does conversion chemotherapy work? Well, further studies which had defined criteria of unresectability have determined prospectively the change in the resectability rate by modern chemotherapy. Fulprecht's now classic study has showed that chemotherapy can increase resectability by at least 30%. So conversion chemotherapy was thus established. And the next question became neoadjuvant chemotherapy. And clearly, neoadjuvant chemotherapy matters. If conversion works, neoadjuvant should work as well. Adam, in this now classic study, has shown that progression-free survival significantly increased after neoadjuvant therapy for resectable colorectal metastasis. Unfortunately, both early and late overall survival has not improved. But collectively, these data on chemotherapy show that response to chemotherapy impacts selection and likely outcome. Recently, Nick Vothe and his colleagues showed the impact of response to modern chemotherapy on overall survival. This study grades response by either as major, complete, or minor, and as expected, the greater the response, the greater the survival. The challenge here is to optimize response without causing hepatotoxicity. Perhaps the overall impact of chemotherapy with hepatic resection is highlighted by this joint study of Mayo and MD Anderson, who looked at stage 4 colon cancers who have a particularly low chance of survival. We sought to determine whether outcome improved over time with increasing the use of chemotherapy and resection. We looked at variable periods, and overall survival increased from an average of 9% to 20%, with a median survival of doubling from 14 months to 29 months. Why? In the right-hand panel, you can see the frequency of hepatic resection had increased dramatically for these stage 4 patients, and on the B panel, that also reinforces the fact that modern chemotherapy was undertaken at the same time, thus reinforcing the importance of multidisciplinary management. In summary, what has chemotherapy done? We used to focus just on resectable metastasis. Now we treat resectable metastasis both before and after planned resection, and we convert a substantial percentage of patients with resectable disease, unresectable disease, to resectable disease. What are the current challenges? I look at these as our current challenges. Molecular markers to oncologically determine resectability, refine neoadjuvant and conversion chemotherapy regimens, and modify resection techniques related to neoadjuvant therapy and functional liver reserve. That is, to look at the response and modify our operation accordingly. I think surgeons have always been probably the best individualized medicine caregivers ever, and so we need to continue with that tact. Molecular markers of tumor biology have now become the new selection criteria because they correlate with both surgical and medical outcomes. In fact, KRAS, NRAS, BRAF mutations strongly correlate with disease survival. KRAS wild type predicts response to anti-EGFR therapy. Adverse prognostic significance has been established both on overall and progression-free survival. Correlation with clinical presentation and recurrence has been documented, and RAS stability, which may change over time, is a temporal biologic marker for these tumors. Tom and Aloya and Nick Vothe have emphasized the importance of molecular markers reflecting tumor biology. However, these markers are still static. They're not dynamic markers of therapy. Example of what's showed on just for KRAS, for example, 30% of the patients will have a KRAS mutation from colorectal carcinoma. They decrease overall survival and recurrence-free survival by nearly 50%. The presence of these mutations suggests that these hepatic metastases are less likely to be oligometastatic, that is, possibly curable. Not all outcomes go as planned. I talked about refining neoadjuvant therapy. This recent EPOCH 2 study has showed that the addition of a biologic tumor marker actually adversely affected overall and progression-free survival. We don't know why that is, but it certainly emphasizes the need for further study and examining neoadjuvant therapy for these patients. Regional chemotherapy has potential, but it's been underutilized. These recent data from Memorial Sloan Kettering show that regional chemotherapy in the setting of with modern chemotherapy as well has impact on survival. Hepatic artery infusion chemotherapy in addition to resection and modern chemotherapy improves survival by 20 months. Although this therapy is very high maintenance for both surgeon and medical oncologists, proof of concept, I think, is hard to refute and offers an opportunity for other novel agents for conversion or adjuvant chemotherapy response. Radioembolization is another less labor-intensive regional therapy which may have neoadjuvant impact in selected patients. However, because of its toxicity, I predict that it will have very limited use in the future. So what about future opportunities? Future opportunities rest in the further coordination of care among colorectal surgeons, hepatobiliary surgeons, and medical oncologists. This diagram touches on some of these factors: modulation of the immune environment, further identification of high-risk cohorts so that we can target chemotherapy better, and continue follow-up of our patients by blood-based biomarkers. And we also have to continue to remember that the balance of the recurrence and treatment with the quality of life. Personalized chemotherapy has come into the age. We now have molecular profiling that has improved strategies in chemotherapy. KRAS, NRAS, BRAF testing guides anti-EGFR therapy, mismatch repair deficiencies and microsatellite instability status affects immunotherapy, and other markers such as thymidylate synthase, HER2, may modify chemotherapy dosing and combinations in the future. So our field is clearly a dynamic one. We've learned that personalized decision-making is affected by even the site of where the colon cancer has evolved. We need to begin our evaluation and treatment after initial patient assessment, assessing the site and characteristics of the colorectal carcinoma. Patients with colorectal and liver metastasis differ a lot and dictate both individualized surgical and medical care. Our prior myopic views of these patients need to change. So in summary, hepatic resection is now safe and remains a major factor affecting outcome for the treatment of metastatic colon cancer. Candidacy has broadened. Selection factors are transforming from phenotypic to oncologic markers, and chemotherapy is the major adjunctive therapy for improved outcome and response of that therapy is probably the most predictive. Sorry. So in conclusion, I think that individualized surgical and medical therapy will continue to improve the outcomes for patients with metastatic colorectal cancer to the liver. The next generation will certainly manage this disease a lot different than from what we did, in greater numbers and with greater success. I look forward to future progress with interest, perhaps still have the time to contribute to the management of these patients. Thank you for your attention.